Hello everyone. On behalf of the KIMS Hospital and especially this Mucor team of the KIMS Hospital, I would like to welcome one and all for this webinar in an unprecedented time. So we call it an unprecedented time because not only our country is hit with a big pandemic, at the same time we are still not only we are struggling with coping up with the pandemic, we have a large number of sudden increase in incidence of mucormycosis cases, and it's almost like an epidemic of cases. So it's really unprecedented time because never in my career, the career lasting more than 3 decades, I never saw so many cases of mucormycosis in such a short time. We used to see these cases of mucormycosis on and off, but usually in an immunocompromised individual. And in this hospital, we used to see at an average of 10 to 15 cases a year. But this sudden increase in mucormycosis has put a lot of stress on the whole system. And throughout the length and breadth of our country, these cases are being reported in huge numbers. So what is this mucormycosis? Mucormycosis is a fungal infection, and we all know that mucormycosis is the spores and sporangia and the hyphae are present all over. They are present in the atmosphere, they are present in the soil, they are present in the decaying food and vegetable matter. So, but they do not cause any harm to a normal person. So when these spores land on the normal mucosa, we have enough immune system in the form of macrophages and neutrophils which fight with this, and we don't get the disease. But this organism causes the disease in an immunocompromised individual. So before this COVID-19, we used to see these cases on and off in severely immunocompromised individuals. So these cases were usually like a patients waiting for bone marrow transplant, or very poorly controlled diabetes or diabetic ketoacidosis, the patients undergoing chemotherapy for cancer or waiting for renal transplant or post-renal transplant, and prolonged treatment with steroids in certain conditions or prolonged use of antibiotics. So we used to see in small number of these cases on and off, and the usual management was debridement with antifungal drugs. So added to the problem of increased incidence, we have a shortage of antifungal drugs, which is causing a big problem in management of these cases. So how this incidence has increased? Just to show an example, like before the COVID era, we used to see 10 to 15 cases a year. And in the previous first wave, when we had in 2020, we used to see slightly increased incidence. I remember Dr. Kalyan and Subramaniam telling me that they are seeing more and more cases of this mucormycosis, and still there were like 15-20 cases more than usual. And in the whole first wave, we saw about 30-40 patients in the whole 1 year of mucormycosis. But just see the number in last 2 months, April and May. Instead of seeing 10 to 15 a year, now we are seeing 10 to 20 cases a day. It is unbelievable. Patient after patient, patient after patient coming with the same set of complaints. Doctor, I had recent COVID. We just recovered from COVID in April or in the last few weeks. And in the last few days now I started getting this nasal congestion and facial pain and the eye symptoms. So patient after patient coming with the same set of symptoms was just unbelievable. I never thought in my career I would see anything like this. Like if 10 patients are waiting outside, 9 are COVID or 9 are Mucor or suspected Mucor, and the whole OT list is only Mucor. So it is a really unprecedented situation, and in the month of May till now we already have done more than 100 surgeries of mucormycosis. such an increased explosion of cases has occurred in the last 1.5 months. So why this sudden rapid increase in incidence? How to explain this incidence? Because in the first wave of COVID, we never had so many cases, and before COVID, though we had immunosuppressed patients, we never had. And why is this coming and hitting our country throughout all the states? No region, no state, all the states. So why are we getting so many cases only in our country and nothing in the rest of the world? That is something which we should look into. So why this rapid increase in incidence? We can only put forward some points based on our experience. I think the first one is definitely the infection itself. Some strain of this second wave which is causing more immunosuppression compared to the first wave. I don't think we can explain in any other way why we get more in this wave compared to the first wave. And of course, everyone knows that unsupervised or injudicious use of steroids and uncontrolled diabetes, these first three are the main cocktail for the fungus infection. So a combination of immunosuppression due to the disease itself with steroids and uncontrolled diabetes. This is the combination we are seeing on most of the patients who present to us. And added to this, the other immunosuppressants like remdesivir or tocilizumab, the monoclonal antibodies, and prolonged use of multiple antibiotics. We have seen patients on doxycycline, azithromycin and whatnot, and multiple antibiotics at the same time. And many patients have this neutropenia which makes them very immunosuppressed. The infection itself causes neutropenia and high ferritin levels. There are so many other things which the other speakers will look into, but all this is a combination of everything, and poor hygiene in administering oxygen, and even post-COVID poor hygienic thing can cause an increase in incidence of this mucormycosis. So to summarize, it's a combination of the COVID-2 infection along with diabetes and along with steroids and other immunomodulators, which is contributing to the onset of this increased incidence of this mucormycosis now. Now there are various types of mucormycosis, so I would ask my colleagues to go into details of that and give you information about each. The most common is of course rhino-orbitocerebral, because the route of entry is usually the nose and sinuses, from where it goes to the eye and then spreads to the brain. So we would deal today with, we have an ophthalmologist, Dr. Pranati, and neurologist Dr. Suresh to go into this. Then other forms can rarely occur like pulmonary and because of inhalation of the spores, the cutaneous if there has been disruption of the skin, and even gastrointestinal has been reported. But pulmonary, cutaneous, orbital, cerebral, gastrointestinal occurring independently of the rhino is very, very rare. So usually the route of entry is in the nose, and some unfortunate patient you can have disseminated where it has a systemic involvement. Now with this introduction, I would request my colleague Dr. Subramaniam to deal with the clinical features and diagnosis of the nasal mucormycosis.
Thank you, Dr. Janardhan, and good afternoon to everyone. Now, I would like to go into this important aspect in the management of the mucormycosis, like how the patient presents, how to arrive at a diagnosis, because this is the mainstay of the outcome and treatment in the management. Because patient will have some manifestations, we must be able to catch it, and then we have to corroborate with our diagnostic tools and establish the diagnosis and go for treatment. If, as Dr. Janardhan pointed out, if we miss any features, we will miss the bus, and the patient has to pay the penalty for it. Now, as it was pointed out, among all the fungal infections, this is the most common one, and next one is the aspergillus. And we have seen during this COVID highest incidence in the COVID patients, post-COVID patients, and no COVID patients, because we are now moving the sea of COVID status. So everybody is, almost everyone is experiencing this problem. As it was pointed out previously, we used to see very small number of cases, but now the incidence is increasing in our institute and all over the state and country also. And in some studies, it is having highest mortality, and morbidity also is very high. And as it was pointed out, it is a common cell, so commonly causes opportunistic infections, commonly seen in the decaying and materials and in inaphic sources. What is the cause? As it was pointed out, the environment, if it is very humid and damp, and if the as regularly pointed out that please maintain social distance. If it is not being maintained, if it is a overcrowding environment, there is a high chance of it to spread. And personally and environmentally, we should maintain our hygiene. If it is not that, we are allowing it to spread fast. And the most important one, in one of the recent studies, was pointed out that regarding the face masks, I have seen some of the people from US also stating that they are washing the mask and they are using it again because of non-availability. That's one of the catastrophe for this, because whenever you want to clean it and reuse it again, you see that it is not moist and it's dry, because any moisture in the mask will facilitate the growth of this organism. And in the resuscitative measures, we are using the humidifiers. If the humidifier liquid, what in the bottle, if it is not cleaned properly, if the fluid is not maintained properly, that also will allow the infection to spread. So also, if the oxygen pipes and oxygen masks, if it is being used to different people in the same sitting, and if it is not being cleaned properly, they are all disposable issues. If it is not being disposed in this era, there is a high chance for it to spread to individually. Why it is occurring? As it is pointed, it is there in the environment. It can enter into the body through any of the means, by inhalations or by inoculations, or with the food by ingestion methods also. Generally, it is seen in the immunocompromised individuals, but also in the immunocompetent individual also it is seen. For our defense, the neutrophils and the thrombocytes, that is platelets, phagocytes, the natural killer cells, they are all helpful in stopping the spreading of the disease. But this causes the neutrophils to drop down and enhance the spread of the disease. The platelets will form as a plug and prevent the organism to spread into the body, but this will cause these thrombocytes will be decreased, and it will facilitate the growth of this. That's why whenever the patient is having in the workup, the platelets and WBC counts are low, please suspect that patient may have a chance to develop this fungal infection. This is particularly commonly seen in the organ and bone marrow transplants, malignant cases, HIV patients, and acidotic states like diabetic ketoacidosis. That also will facilitate, acidic environment will facilitate. Nowadays, there is an increased trend in using iron and zinc in individuals, but in one study from Chandigarh, it was pointed out that high levels of iron will facilitate the growth of the organism. So see that level should be optimized. And the malnourishment, like protein energy malnourishment, that also will facilitate the growth of the organism. And it was pointed out already that prolonged and indiscriminate use of antibiotics and steroids will facilitate. And this COVID state, as I pointed out, post-COVID COVID or no COVID, all these things also will help in the growing of this organism. How it presents to us. In one of these series, or in our series, we have seen so many people are presenting with periorbital edema, retroorbital pain, proptosis, and ophthalmoplegia, impaired vision. In one series, it is pointed out that the vision loss is high, like 85%, and the ophthalmoplegia is coming standard, second in the 67%, and proptosis. And in the nose, we see so many dark colored crusts. And if the disease advanced with intraocular lesions, the patient may have headache, fever, and altered sensorium also. So these features you must catch and then work up to arrive at a diagnosis and management also. So don't neglect that this vision loss, ophthalmoplegia are just simply related to eye only. It's related to the nose also, and this mucar will have tendency to cause all these symptoms, and we must be able to catch it. How this is causing the spread? The mucar has a propensity to invade the endothelium, and it causes the damage the endothelium and causes angioinvasion. By this, it causes either hemorrhage or thrombosis. With that, the blood supply to the organ is decreased, leading to tissue necrosis, and that's why it leads to formation of this black colored clusters in the nose, involving the mucosa, turbinates, nasal septum, and all other structures. And then once it crosses into the blood, it causes fungemia, and wherever it reaches, it causes multi-organ damage and ultimately to the death of the person. Why this mucar is very aggressive? Because it is resistant to heat, and it has a propensity to grow very rapidly by breaking the immune system of the host. And another thing is, this mucar is resistant to most of the antifungals except the group of drugs like amphotericin. Sometimes, some people, if by mistake we use voriconazole in the treatment of the amphotericin, it leads to the growth of this organism. As it was pointed out by Dr. Janardhan, there are different types of there, like rhinocerebral, rhinoorbital, pulmonary, and disseminated, depending on the organs involved. And there is a staging, in clinical staging for the disease. If it is confined to the nasal mucosa and sinuses, it is graded as stage 1. If it is going into the orbits, it is graded as stage 2. And if it is going to cerebral and intraocular spread through ophthalmic artery, or superior orbital fissure, or cribriform plate, it is stage 3. This facilitates what type of treatment you have to go, and what type of surgeries you have to do, and how the management you have to do. That also will help in this staging. How to arrive at a diagnosis? Whenever the patient comes to the OPD, we have these all armamentarium like endoscopy, radiology, biochemical testing, pathology, and microbiology. If time permits, if the patient is safe, non-COVID, we can go for endoscopy, and it shows, as it was pointed out, the dark colored crust along with infective material in the nasal cavity. Once you see this, you can suspect the diagnosis, and also you can take a swab from this and you can send for KOH mount for the early diagnosis. The radiology plays an important role in the diagnosis. You see, in this case, just the nasal mucosa and maxillary sinus is involved, almost like an early stage. In this, the orbit is involved, rhythmoids are involved, and the sphenoid also is involved. They are all the patients who presented to us in our OPD. Here, this unfortunately is having extensive intraocular environment in a young, around 46-year-old gentleman. He underwent surgery, is receiving antifungals, but ultimately the outcome is not that good. So, this is having rapid intraocular extension. Here, we see the involvement of the cavernous sinus and orbital apex and optic nerve. In this case, there is isolated sphenoidal sinus involvement with no other sinuses involved, and it came as mucar. Suppose in assessing the prognosis and for the early diagnosis, any non-invasive technique is there. Some of the tests like the biochemical markers like beta-TD glucan and galactomannan assays, they are helpful for the early diagnosis of invasive fungal sinusitis, especially in aspergillus. So whenever possible, we can do this test and we can predict the disease. Once you take the sample, we can go for the microbiological assessment like for KOH mount and also we can send the tissue for culture, and we can see this is the mucor and this is the aspergillus, and in the culture we can see the colonies of the mucor and aspergillus. When we send the tissue for frozen biopsy or routine histopathological examination, here also we can arrive at a diagnosis. This is the acute branching, the mucor organism. This is the aspergillus, and you can see a fruit ball of the aspergillus nicely declared and help it in the diagnosis of the disease. This is a mucor. And in one of the other microbiological examinations is, we can suppose if the patient is not fit for surgery, and if the condition is not good, and we suspect mucor, we can send the blood for culture sensitivity, nasal swabs for KOH mount, and also we can arrive at a diagnosis. So in nutshell, whenever you suspect any individual, or whenever the patient presents with any these symptoms, have a high degree of suspicion, because the early diagnosis and the aggressive treatment at the earliest will clinch the outcome. So before diagnosis or before treatment, have a high degree of suspicion of the individual. How to make an early diagnosis? Whenever the patient lands in with the complaints of watering of the eye, when there is swelling of the eyeball, when there is redness, you should have an idea that unless put otherwise, this patient may be having mucor. And there are some protocols laid nowadays because of this pandemic by All India Institute of Medical Sciences and the Association of Autoradiologists India, Pune. Like, according to them, as far as possible, if feasible, do an ENT examination whenever you suspect, and if possible, go for an nasal endoscopy. But before this, suppose if the patient is a COVID patient, be careful doing this test. Other one is assess the HbA1c level, because as it was pointed out, immunocompromised individuals have high tendency. So diabetics is one of the common. So if the HbA1c is high, we can have an assumption. And so also better to have a CT scan of the paranasal sinuses, so that we can see beforehand if before the disease spreads to extensively. Thank you.
Thank you, Dr. Subramaniam. We know how eye is part of the ophthalmologist, is part of the very important part of the whole mucor team, because most of the symptoms, most of the patients have eye symptoms too, and most of the surgeries are done along with the ophthalmologist. So I would request Dr. Pranati to enlighten us on the orbital symptoms and the treatment part of it from ophthalmology point of view.
Good afternoon, everyone. Today, the topic of discussion is rhinoorbital mucormycosis. I'll be covering the orbital aspects of the mucormycosis. As we are all seeing now, the mucor has become an epidemic in this COVID-19 pandemic. Compared to the last wave, this wave we are seeing a lot of number of patients who are coming with the mucormycosis, and the number is increasing day by day. As sir pointed out, every day we are seeing only mucor cases in a regular OPD, not even a single normal patient. And our state Telangana is one among the states which have been declared seeing highest number of mucormycosis in India. What is mucormycosis? It's basically an invasive fungal infection which is mainly seen in the immunocompromised individuals. With the involvement of all the sinuses, and it spreads then to the retroorbital space and then to the brain. Sir has already discussed about the risk factors. What I want to highlight in this is the degree of severity of the infection and even the morbidity and mortality of the patient. We are correlating directly with their uncontrolled diabetes mellitus. I mean, we are seeing in all the patients who are presenting to us with the orbital symptoms, their blood sugars are very high, ranging between 400 to 500. And another risk factor which have been observed is those patients who have other immunocompromised status like leukemias or HIV. Those patients are also having a very bad disease. I mean, these two categories of those patients, we are seeing extensive involvement of the eyes. Sir has already discussed about the pathogenesis. What I just wanted to highlight is the symptoms which we see in the eye are not just because of the soft tissue invasion, even because of the angioinvasion causing thrombosis and the tissue necrosis. We are seeing symptoms, and the perineural invasion of the disease is main risk factor which is causing the disease to spread from the peripheral nerves to the central nervous system. Coming to the symptoms of the orbital mucormycosis, the symptoms vary depending upon the time of presentation of the patient to our department. Some patients, because of increased awareness which is being now in the public, they're coming to us with the very early symptoms of eye swelling. I mean, basically a periorbital edema, I should say. In this stage, the patient, they'll not have any other symptoms except for the periorbital edema, and they give an history of either COVID-19 or recovered from the COVID-19. And and some patients, they go on to the next stage, as I've shown in the picture, with the drooping of the eyelids and inability to open the eyelids on their own, and they even come with the protrusion of the eye, mild to severe protrusion of the eye, and with the limitation of the extraocular movements. I mean, they may not be able to move the eye in any direction, and along with that, this is all like the disease has spread more into the orbit. Even we are seeing the patients coming to us with the swelling inside the eye, around the eye, redness, and this redness is basically in the early stage as well as in the late stage we are seeing associated with a lot of pain in and around the eye. And the vision symptoms of the patient, they may see doubling of the image, or there may be sudden decrease of the vision, and in the severe stage there may be even total loss of the vision. The patient approach, I just want to emphasize few factors related to the mucor, because most of the patients now, because of increased awareness also, any eye symptom they're thinking of mucor and they're just running to the ophthalmologist. That's what I told initially. Our ophthalmologist is full of the patients with the COVID or post-COVID with the suspicion of mucor. So detailed history taking is very important with respect to approach to the patients. I mean, it should not only include whatever their symptoms, even the history of whatever drugs they're using. Some patients, they're just using the antifungal drugs on their own, suspecting that they have already got the mucor symptoms. So we need to take the detailed history on what are drugs they're using, and if they were admitted in the hospital, what was the duration of the stay, what were the systemic steroids they were given, and how was their condition at the time of discharge. And even history of comorbidities like diabetes and usage of immunosuppressants is very important, because some patients we are seeing, those who present to us when we have to plan up for the surgeries and all, they may be having other comorbidities like chronic heart disease and CKDs. One of the patients which I have seen last week, he came to us with the pacemaker in the heart, and outside they were already advised MRI. I mean, in such case, like before you order some investigations, you need to take complete history of what all diseases they have, so that we can ask the technician to switch off the pacemaker before we take for the MRI. And even the other things which are most important is like how long they were on prolonged ventilator or any other oxygen therapy or any other immunomodulators which they were using. And the onset of symptoms and their progression and severity, this is a must to be documented, because how we have to address the treatment, I mean how aggressive we have to be in their course, depends on that. Because some patients we are seeing in the OPD and we are asking for the investigations, and maybe within a day or two they are just going blind. So detailed history taking, I mean, some patients, they may have fast progression if their sugars and all are uncontrolled. So you need to concentrate on how severity is the infection. And coming to the examination part, this is also very important, because as I told you, most of the patients are relating all their eye symptoms to mucor itself. And the other day I had seen a patient who had total cataract. It's a mature cataract with the decreased, with no vision at all in that eye. but he would have never closed the other eye and would have checked his vision. Because of seeing in the newspaper and all other things, he came to me running saying, "Madam, I'm not seeing my eye since today morning." When we examined, it was a total mature cataract and he didn't have any other symptoms. So we cannot just go by imaging or any other thing that this patient is having mucar and all. First, baseline examination, which includes unaided visual acuity and again the best corrected visual acuity. Some patients, they don't know they have a refractive error. We had seen myope patients coming to our OPD saying they have decreased vision because of mucar. They themselves diagnose them as having mucormycosis, but it's a simple refractive error. And after we do the complete refraction, we have to check the extraocular movements. This is also important because some patients may be having squint by birth, or they may have some injuries in the previous history. So now whatever eye symptoms they notice, they start correlating to the mucar. So I'm not saying that we are not seeing mucar, but we have to be vigilant and we have to be advising to our patients whether it's really mucar or something else. And applanation tonometry is mainly to check the intraocular pressure of the eye. This is also important because I'll be telling about the injections which we'll be giving to the patients for the conservative treatment. So baseline intraocular pressure examination is important to monitor if there is any rise in the pressures in the treatment period. And slit lamp biomicroscopy is to examine their cornea and other things. Most important is the fundus examination. Today morning only I had seen a patient who had come to me with the mucar as well as proliferative diabetic retinopathy. So mucar is there in the nasal mucosa and paranasal sinuses level, and it has just encroached the middle wall of the orbit in this patient, but he was told elsewhere to go for exentration, already advised by the other colleagues of mine, without doing a fundus examination. This patient whom I am discussing, he has complete loss of vision, but it's not because of mucar. He is having a proliferative diabetic retinopathy with a vitreous hemorrhage. So fundoscopy is a must, whether it's a COVID positive or COVID negative. Before we plan up any treatment, we have to do the fundus examination of the patient. And this investigation part, sir has already covered. And coming to the imaging also, we need to look for certain MRI imaging, we need to look for certain factors which clinch our diagnosis. In the early stages, there may be orbital fat strand link and thickening of the extraocular muscles and middle orbital abscess, and there may be intraconal perineural sheathing. When it's a disease is very advanced, we see the globe tenting. Coming to the management part, management of the orbital mucormycosis mainly depends upon the staging of the disease, which has been suggested to us in All India Ophthalmology Society by Dr. Santosh Anawar sir. So according to our staging, stage 1 is mainly the involvement of the nasal mucosa. Stage 2 is the paranasal sinuses involvement. Stage 3 is the orbital part. In the stage 3, we divide it into A, B, C, D depending upon the extent of involvement of the disease. Stage 3A is only involvement of the nasolacrimal duct, middle orbit, but vision is unaffected. Means you may be seeing the first picture where the eye literally looks almost near normal. These patients may be having just mild pain around the eye, and they may be having the nasal symptoms predominantly. And next is the 3B. 3B is the stage where there is diffuse orbital involvement, where you are seeing the diffuse periorbital edema in this case. And in both the 3A and 3B, there is no involvement of the vision, means the vision is unaffected in these patients. So 3A and all those patients who have in the stage 1 and 2, aggressive debridement of all the paranasal sinuses is required. And even those patients who are in stage 1 and 2, or any patient whom you have a suspicion of mucar, you need to have a baseline ophthalmic examination, because we never know when this patient from stage 1 will jump to stage 4. So in stage 1 and 2, aggressive debridement of all the paranasal sinuses is required with the clean margins. And in the patients who have stage 3 and 3B, along with the sinus management, we need to give some injections, retrobulbar amphotericin B injections, that I'll discuss in detail how to give and all. Next is the stage 3C. This stage is an extensive disease stage where the disease has spread into the orbit, causing central retinal artery occlusions, or there may be ophthalmic artery occlusion and superior ophthalmic vein thrombosis, inferior and superior orbital fissures involvement, and there may be involvement of the apex of the orbit with the total loss of vision. Means in the picture you can see the patient eye is totally red with the proptosis and it's total swelling of the eye. There is no movement of the eye. I mean, in all the directions, the movement is restricted, and there is complete loss of vision. In stage 3D, there is same symptoms we see in both eyes, that is bilateral orbital involvement. In both the stage C and D, the treatment of along with the aggressive debridement of sinuses, patient need to undergo orbital exentration. Stage 4 is the involvement of the central nervous system, which I think Dr. Suresh sir will deal in detail. But whatever the stage of the disease, once it starts involving the orbit, we need to address the disease to prevent further progression of the disease. So in stage 4 also there is a role of orbital exentration as long as the patient is fit for surgery. If the patient is not fit for surgery, then we need to go for the supportive line of management. Coming in detail about the injection part which I was telling you, this transcutaneous retrobulbar amphotericin B is the treatment of choice which we are advocating in those patients who present to us in the early stage, because as I told you in the first wave, I had seen particularly hardly 8 to 10 cases. All those patients, they presented to me with the complete loss of vision in the stage 3 CRD. But in this wave, maybe because of increased awareness, they're coming to us as soon as they get the nasal symptoms. So this wave, we started giving transcutaneous retrobulbar amphotericin B injections. I prefer to use a liposomal amphotericin B for this injection, but even deoxycholate form also can be used. We are taking a 50 mg liposomal amphotericin B vial and mixing 10 ml of sterile water to that. And after that, I'm taking around 0.8 ml and giving into the in the retrobulbar space of the eye wherever the disease. I mean, if it's the middle orbit which is involved, then in the middle position, or if it's the inferior orbit, then in the inferior position. Basically, around 3.5 milligram per ml of the drug has to be injected at any one sitting. Means we are repeating the injections again after assessing the patient the next day. As I told you, some patients, they will have, after this injection, we are seeing some amount of inflammatory reaction. So we need to reassess the patient after giving the injection the next day, and we may repeat it again alternate day. Around 4 to 5 injections have given for each patient, and these patients, the main indications of giving this transcutaneous retrobulbar amphotericin B is mainly to prevent further progression of the disease. So we advocate these injections in those patients who have a disease which is confined to the sino-orbital disease, and those who have a preserved vision and there is minimal orbital involvement with the thickening of extraocular muscles and the abscess is localized. Or one patient I'm giving in whom there is only apex of the orbit involved, and he has a good 6/9 vision. As long as the patient is maintaining vision and there is no spread of the disease to the brain, we can keep giving these injections on alternate day basis along with the systemic antifungal therapy to prevent further progression of the disease. But one thing we have to make sure is there is enhancement of these muscles on the imaging in the with the contrast, because the drug will act only if the vascularity is still there. If it's already necrosed tissue, there is no point in just keep on giving the drug when really we have a scarcity of amphotericin B. And next thing, this is the surgical debridement. Even this also, I'm with the ENT colleagues' help, I'm just advocating them to do the surgical debridement in those patients who have 3A and 3B disease, where along with their extensive debridement of sinuses, I'm asking them to go ahead with the endoscopic orbital debridement so that most of the devitalized necrosed tissue, which is acting as a nidus for the disease, it will be removed, and simultaneously we are keeping here Surgicel over the orbital fat after the medial wall resection, which is soaked in amphotericin B, and even this is showing a lot of good results. I mean, those patients in whom where intraoperatively medial wall resection is done and the amphotericin B is, I mean, irrigation is done, they are showing good results without progression to the C and D. And even along with the medial wall resection and the amphotericin B there, even the sinuses lavage with the amphotericin B intraoperatively also plays an important role to prevent the progression of disease. Next is the orbital exenteration. It's a radical procedure. It's quite mutilating and quite disturbing to the patient also. But to salvage the patient life, we need to do it under general anesthesia, where entire orbit is removed along with the extraocular muscles, optic nerve, and the orbital apex. And we keep debriding. I mean, we need to keep removing all the tissues in the orbit until we see the end point as the bleeding. After doing the orbital exenteration, the post-op care is also very important, because I have seen couple of patients where we have done exenteration in one eye, and because of inavailability of the antifungal drugs and all, they have developed symptoms even in the other eye also. We need to keep monitoring these patients for further to prevent the post-op complications even in the eye which has been exenterate. Basically, it's the daily dressing of the wound with the proper betadine cleaning of the suture line and application of the antibiotic ointment with the regular follow-ups, because we have seen in some patients where their sugars were uncontrolled, post-operative wound gape, and again secondary infections. So just exenteration will not end the treatment there. We need to have a good post-operative care of the wound and all, along with the systemic antifungal therapy. And last is the rehabilitation part. Once these patients do get out of this mucor, this one with antifungal therapy and all, then we can provide them with the spectacle mounted facial prosthesis. Usually we do it after 3 to 6 months. Thank you.
Thank you, Dr. Pranati, for very informative lecture. So the mainstay of the treatment is surgical debridement and medical treatment. But we all know is the medical treatment is the one which cures the patient. The surgical debridement, the surgeon's role ends that after he debrides or a couple of days of follow-up, but it is a physician who follows up this patient for a long time, weeks and sometimes even months, till the patient gets completely cured. In many places, the physician is actually the leader of the team of Mucor team in the hospital. So the important person in the whole team is the infectious disease specialist who manages these patients pre-op and post-op. So I request Dr. Pratik, our ID specialist, to enlighten us and tell us how he plans the management of these Mucor cases.
Good afternoon, all. Yeah, so like already sir has pointed out, we are all facing the challenge of mucormycosis right now, and we are struggling to treat these patients because obviously we need to debride it, but the present scenario, the antifungals are a rare commodity. It's not easy to get the antifungals, leave alone what is the best antifungal available. So we have to manage with whatever we have. So what is the ideal treatment and what is the practical in the current times? So that's what I'm going to discuss in next 10 minutes. So now this is what we have been hearing from the news: black fungus, then came white fungus, and then it's yellow fungus. Is it really truth, or it's all color coding is just it's so practically or medically speaking, this is a misnomer. There is no mucor is not a black fungus. There are different type of fungus which are black, and so we are going to discuss about mucor in the next 10 minutes. So white fungus is a different fungus. It is not as life-threatening as mucormycosis. I'm not sure what is yellow fungus exactly it is. Okay, so when we deal with fungal infections, we usually categorize them into the yeasts, which are usually the candidas, which we know, then molds, which are your mucor and aspergillus, and there are some dimorphic fungi, which could be yeast in some form and in molds in the other forms, depending on the environmental condition and other things. So in yeast, you see that they have pseudohyphae. They are slimy in appearance, and the types of fungus in yeast are Candida and Cryptococcus. These are the few yeasts that you see. The molds, when they grow on the culture, they look filamentous. They have hyphae, and the culture growth looks furry. So then aspergillus and mucorales, these are the two main filamentous fungi. How to differentiate between the two? The aspergillus usually have thin filaments. When you look at the LPCB mount, they have thin filaments, or the KOH, and they have acute angle branching. And the mucorales are the classic description for mucors. Zygomycosis is they have a broad aseptate ribbon-like filaments. So if you see this description, it is the mucormycosis. And then you have dermatophytons. And there are some other dimorphic fungi, or also called sometimes these are endemic fungi, which we don't see very oftenly. So coming to our topic of the day, mucormycosis. These are the infections caused by the mucorales, and it belongs to the category called zygomycosis. There are many other types among that. There are only few centers which speciate the mucorales into the different species. There are some significant events associated with that, but I don't think we can discuss in such detail here. So invasive fungal infections are difficult to diagnose very early, but mucor, we have to be very vigilant. If the diagnosis is delayed, or if it is not diagnosed correctly, you have a high mortality. That's why it's very important to make an early diagnosis, especially in people who have risk factors. So these are the principles in the treatment of mucormycosis. First, risk stratification for the severity, which is already been discussed, and then it's the intense attempts to early clinical and laboratory diagnosis to start the treatment early and plan the things accordingly. So early initiation of antifungal therapy, which can be a monotherapy and or combination therapy depending upon the disease. And then surgical debridement. This is another important aspect. So for treatment of mucor, I would say all three are equally important. Nothing is less important. There are three important things. One is obviously surgical debridement. So you have to get rid of as much as necrotic or infected tissue is there. You have to debride as much as possible. There is no conservative strategy for mucor. It has to be radical debridement. And then next comes your antifungals. So we have to use it. I will come in details about the antifungals shortly. And third is reversal of immunosuppression. So whatever is the underlying cause or predisposing factor, let's say uncontrolled diabetes, diabetic ketoacidosis, or steroids, all this if possible has to be reversed. And then it also says that if there is underlying medical condition, it has to be also controlled. So these all three are equally important. You cannot have good outcomes with just one. You need all three. So that is the emphasis here. Just surgery is not enough. Just antifungals are not enough. So surgery, I have already told it that it is important, and already the surgeons have described about it. So just about this, what about no treatment? No treatment is not an option, and it's universally fatal. 100% there is a death. So if you when we talk about the antifungals, there are two antifungals which are first line antifungal therapy: amphotericin B and isavuconazole. These are the two first preferred medications as far as the antifungals go. However, posaconazole is another drug which is available, but if it's in the ideal situation, it is the third line or the salvage therapy. So in the best possible conditions, amphotericin B, that too the lipid formulations are the preferred ones, along with or as an alternative to isavuconazole. Now the lipid formulations can be different formulation. It can be a liposomal amphotericin B, it can be a lipid complex, or it can be a emulsion form. They have a better therapeutic index than the conventional amphotericin B deoxycholate, and that's why they are considered as the first line therapy compared to the deoxycholate or conventional amphotericin B. So what about the lipid formulations? So they are the drug of choice. They have better therapeutic index. I already told you what are the forms available. The dose, this is more important here. The dosage. You cannot have compromised dose as far as the treatment of mucus is concerned. What mistake most of the times happens is we underdose. The dose required for the mucormycosis is 5 milligrams per kg per day. So on an average for a 60 kg man, you need 300 milligrams dose. So many times it happens that people use around lower dose, which is ideally used for the aspergillus, the 3 milligrams per kg. That dose is used very often, but ideal dose is 5 milligrams. So if it is available, better to use the maximum of 5 milligrams per kg dose. This is the minimum I'm saying. Although initial recommendations were suggestive of the dose has to be between 5 to 10, there are still some scenarios where we have to consider the higher dose, especially in the CNS disease or when you have a bone or joint involvement. In those cases, we have to consider the higher dose up to 10 milligrams per kg per day. Now coming to the newer triazoles, basically it is the isavuconazole and the posaconazole. They act by depleting the ergosterol from the fungal cell wall. The fluconazole, the older ones, the fluconazole, itraconazole and voriconazole have very little or no activity. You can say it's almost no activity, so they should not be used. The voriconazole, if somebody is on prophylaxis or treatment with voriconazole, you can have a higher risk of infection with mucormycosis because of the selection pressure. And the newer triazoles, they have the activity, not the older ones. So coming to the posaconazole, it is a well tolerated azole which has very little gastrointestinal side effects, and it is available in 3 different forms. Oral suspension was most widely available previously, and it was administered 3 to 4 times a day with food which was high fat containing food, so that the bioavailability is better. That reason for the low bioavailability was the acidity. It affects the bioavailability and the drug or the food interactions. So that's why you need to take it with the high fat meal. Now recently the tablet formulation has come, so which is good in a way. So it doesn't have much of a drug interactions, doesn't have much food and drug interaction. The absorption is better, so the drug levels reached in the serum are much better predictable, so they are definitely preferred over the syrup formulations. So another problem with the posaconazole in the ideal scenario is you have to have a TDM, that is therapeutic drug monitoring, so that you know whether your drug levels achieved are in the optimal level or not. So posaconazole, as I said, oral suspension, you can use it 2 or 4 times a day. If you are using as twice daily, it has to be 4 mg twice a day. 400 milligrams, which is equivalent to the 10 ml of syrup, or 200 milligrams 4 times a day. Again, that too if it is not taken with the meals. And again, I'm re-emphasizing here that it is to be considered as a salvage treatment, not the frontline treatment. Frontline treatment with posaconazole is only considered in cases where treatment with amphotericin B is absolutely contraindicated, like in patients who have acute kidney injury or who are on CKD but not on dialysis. But in practical scenarios, it is the last option. So if available, isavuconazole has to be used if it's available. Coming to isavuconazole, again, as I said, it's a newer azole. It has a prodrug which is the isavuconazonium, and it is approved in US as well as in Europe as a frontline treatment of amphotericin B as a replacement for amphotericin B when you cannot use it for any reason. And a good thing about it is also available in the IV and oral formulation. The dosage is 200 milligrams 3 times a day for first 2 days and 200 milligrams daily after that. So be it IV or oral, the dosage is the same. So it has many plus points compared to the azole or even amphotericin B. It is very safe. It has very steady or linear pharmacokinetic and pharmacodynamics, so you don't need a TDM levels for that. It has almost none drug interactions. It has very less toxicity, especially hepatotoxicity, and is very less. no skin or ocular side effects. There is no there is sometimes QT prolongation can happen, but again very rarely we have seen cholestatic hepatitis with isavuconazole, but not very common. Again, it doesn't have nephrotoxic silodextrin in the IV formulation, so even in patients who are having kidney injury, you can use it in the normal dosage. There is no dose adjustment required in kidney or liver failure, or even in obese patients you don't need dose adjustment. So basically it's the single standard dose. You don't need to worry about what is the dose per kg. All that thing is not required. Again, it has a excellent oral bioavailability, nearly 90%. So we can say that IV and oral are equally efficacious. So if you have IV initially for few days, and once the overall patient condition is stable, you may switch to the oral tablets as well. Now, role of combination therapy of two different type of antifungal agents. There is no definitive data that the combination therapy helps. There is limited data to support combination of polines and azoles or polines with echinocandins. But again, echinocandins as a monotherapy, definitely no role of single echinocandins like your, because I'm getting frequent messages from the patients saying, can we use anidulafungin, can we use micafungin, can we use the caspofungin? You cannot use them as a monotherapy. There is small animal data where the amphotericin can be combined with echinocandins, and there has been some benefit, but not as a monotherapy in the absence of amphotericin B. Coming to the combination of amphotericin B with azoles like posaconazole. Isavuconazole, if you have monotherapy is good enough, you don't need to combine with posaconazole, the amphotericin B. There are times where we have to combine amphotericin B with posaconazole, but theoretically they may have the antagonistic effect. But in situations where when the disease is progressing despite on treatment with monotherapy, you can consider posaconazole in combination with amphotericin B, or in CNS disease you can still consider it. So, but there are risks involved, but that's why it has to be your last option as a salvage therapy. So what about the adjunctive therapy other than these three what we have discussed? That includes the reversal of immunosuppression, tapering or transitioning to the non-steroidal immunosuppressive drugs if it's possible. Aggressive glycemic control is of paramount importance. Hyperbaric oxygen can be tried if it's available. This is another question that I get it very often, that what is the treatment duration? There is no standard treatment duration for mucormycosis. You have to treat as long as patient is better clinically, radiologically and laboratory wise. So you have to treat it as long as possible. Preferably it is better to use IV medications for 2 weeks or 3 weeks, and if you see that there is a good control over the disease, then you can switch them to the oral formulations. That too, preferably an isavuconazole. Subsequently, maybe you have more control, your CT scan or the MRI images show that there is almost complete eradication of the disease. That time you may switch to the posaconazole if given in the best possible situation. No, it's too small here. Okay, fine. So this is the algorithm, which is the guideline based. There was a global guidelines for the treatment of mucormycosis. This is what it says when you have all drugs available, how to treat in the best circumstances. So first preferred drug is your liposomal amphotericin B. Here you can see that the green ones here are the preferred drugs or the preferred mode of treatment, and the red ones are to be avoided, or when you don't have anything, then only you should use it. So liposomal amphotericin B can be used as the first line. If there is any brain involvement, you can use the higher dose, that's 10 milligrams per kg. In normal cases 5 to 10, at least 5. So if there is a solid organ involvement, again the higher dose has to be considered. If there are patients who have renal problems, then isavuconazole or IV posaconazole can be considered. So obviously among the three formulations of posaconazole, IV is the best one or to be preferred, because you get the better and predictable drug levels in the blood. After this, you can consider, if in cases if it is not available, then again isavuconazole, posaconazole are the next option in general patients after the liposomal. Here in this chart you can see the conventional or deoxycholate amphotericin B has to be avoided, but we are in a situation where nothing is available, so we have to make use of it. So how to use it? The dose is 0.7 to 1 milligrams per kg of the conventional amphotericin B, and it has to be diluted in 500 ml of dextrose to be given over a longer infusions. If you see the standard recommendations, they say that up to 4 hours it has to be given, but to reduce the chances of nephrotoxicity, you can increase the infusion duration to 8 to 12 hours. Watch it for a few days. If the things are okay, the patient is tolerating the amphotericin B well, then you can reduce the duration of infusion. Another important thing that you need to do is hydration. When you are using the conventional or even for that matter liposomal, but obviously more when you are using the deoxycholate form, make sure that patient is hydrated well. Once the amphotericin B infusion is over, you have to give the patient the hydration with the normal saline or any fluid which is appropriate for that condition. Third problem that happens, another problem that is there with amphotericin B is the electrolyte imbalance. So you have to keep watch over the electrolytes, especially the potassium and magnesium, and correct it accordingly. So once you are done with the initial treatment for 2 weeks, you have to reassess. And if you have a steady disease, a stable disease, or there is a partial response, then you can switch to the peroral formulation of isavuconazole, or if it's not available, then posaconazole. That's the next alternative. However, if there is a progressive disease, then you can continue the primary regimen, like if it was a liposomal amphotericin B, and if you are using a lesser dose, maybe you can hike up the dose to 10 milligrams. Isavuconazole, posaconazole can be added if there is a progression of the disease. If you get toxicity with the previous regimens, you can switch to the different class of drug. And this is the algorithm to be followed when the liposomal formulations are not available. So obviously here the choice is your isavuconazole first and posaconazole. IV formulation is preferred always, especially in the early disease, then the oral formulations, and last option can be your liposomal amphotericin B. Sorry, the conventional form of liposomal amphotericin B. Again, after response assessment, you have to assess the patient clinically at least once in a week, preferably by imaging. If you have some doubts, you should have a low threshold for repeat imaging, and the medications has to be optimized accordingly. This is where you don't have the isavuconazole and posaconazole, which is not available. Then you can continue to use liposomal amphotericin B or the deoxycholate. So that is how it is. So these are the ideal scenarios against salvage. So just to summarize these things, I will say you need an early and extensive debridement. Liposomal forms of amphotericin B are preferred. If you don't have it, try to get the isavuconazole, preferably an IV form. If not, oral is good enough and still maybe better than even IV posaconazole. So that should be your the preferred drugs. First is liposomal, second is isavuconazole IV followed by oral, then IV posaconazole. Maybe in that case, if you don't get anything, then I will consider the deoxycholate form of amphotericin B, because it is the better drug than posaconazole tablets and syrup. If you don't get, then the option is posaconazole tablets. The last tip, syrup, posaconazole. Another thing I just wanted to add is that one surgery may not be enough. So you may have to relook again and again. If there is any debris or additional infection coming up, you may have to do the repeat debridements. That's also equally important. So one surgery is not enough sometimes. So that's it. Thank you.
Thank you, Dr. Pratik. Mucormycosis is one disease where without surgical debridement, the mortality can be as high as above 90%. So now to take us through some surgical principles of this debridement, I request Dr. Kalyan, my colleague, to talk.
Yeah, good evening, everybody. Coming to the surgical intervention of mucormycosis, which is also plays an important role. So, surgical intervention is the key control to eliminate the mucormycosis with the antifungal therapy is the gold standard. So, the main role and the aim of the surgery is removal of devitalizing tissue, debulking of infected tissue, tissue biopsy for diagnosis, confirmation, and faster action of antifungal agents. So these are the prerequisites for the surgery. So basically, as already explained by the my other colleagues, so these risks you have to all consider, like surgical profile, RT-PCR, HRCT scan to know the status of the lung, present lung, because the patient may go into ventilatory support. The cardiac clearance you have to get it, pulmonary clearance, ophthalmology checkup, and neurosurgery checkup or neurophysician, and obviously pre-anesthetic checkup, which is again one of the most important to do the surgery in a local or general anesthesia. So surgery consent is obviously these all surgeries are high risk, and we have to take a consent for all the surgeries performing, like endoscopic sinus surgery, maxillectomies, and the patient may require ventilator support and even orbital excenteration and all these. So surgical management basically depends upon the staging of the disease. So the stage 1 is limited to the nasal mucosa, the 1A limited to the middle turbinate, 1B involvement of inferior turbinate and nasolacrimal duct, 1C involvement of nasal septum, 1D involvement of bilateral nasal mucosa. Whereas in stage 2, the involvement of paranasal sinuses, 2A is one sinus, 2B is ipsilateral sinuses, 2C more than 2 ipsilateral sinuses, palate or even oral cavity is involved. In 2D, bilateral paranasal sinus involvement, palate or zygoma is involved. Whereas in stage 3, it is involvement of the orbit, which is already been explained by ophthalmology colleague, and stage 4, which will be covered by Dr. Suresh, the neurophysician. So obviously, in my opinion, the mode of disease spread, basically the sinus, ethmoidal sinus, basically involvement of medial wall of orbit, whereas maxillary sinus, it involves the inferior wall of the orbit or the upper alveolus. Sphenoid sinus involvement shows median pterygoid, lateral pterygoid, and apex of orbit, and cavernous sinus involvement. And the frontal sinus, it involves the frontal lobe or even the medial wall of the orbit also. So treatment of stages 1, 2, 3A and 3B. Aggressive debridement of all sinuses, maxillary antrostomy, basic endoscopic sinus surgery, we do maxillary antrostomy, then followed by ethmoidectomy, frontal sinusotomy and sphenoidectomy. And where you don't have an access to the maxillary sinus inferior wall or the anterior wall, we do inferior turbinectomy or Denkes approach. And even we do middle turbinate resection, followed by orbital decompression and partial or total maxillectomy. Obviously, in most of the cases, we avoid total maxillectomy because of the prognosis. So stages 3C, 3D, 4A and D or orbital decompression, extensive debridement of the tissues is required. And stage 4C and D surgery is performed if systemic condition permits, otherwise only supportive treatment salvation. So surgical debridement is the fundamental for success management of mucormycosis. With angioinvasion or extensive necrosis, antifungal therapy alone is inadequate for control of infection. Surgery should be considered early in course of treatment with complete removal of infected or necrotic tissue. Survival of the patient depends upon both medical and surgical approach. So it is must that even you may have to do repeated debridements and followed by amphotericin, liposomal amphotericin intraoperative wash or some packing material we have to implement. For maxillofacial infection, limited surgical dissection is preferred rather than total. So these are the intraoperative mucormycosis pictures. So normally when you see, put an endoscope and see, it looks to be very normal. So unless so we have to do and search all the sinuses. So first we have to search for the tissue, so that we send it for the frozen. And in the case we have got a luxury for because of the good pathology and microbiology, we send it for the frozen. where we get the report within 20 minutes. Then when the mucor is confirmed, then we do an aggressive line of approach for the sinuses. So isolated sphenoid sinus also, we have seen many cases where the patient has gone into some visual loss, spreading an intracranial extension through cavernous sinus. And one more is, when the initial stages, orbital, where the orbit is involved, where the proptosis you have, so endoscopic orbital decompression is must. So we first expose the bone over the periorbita, then we incise the periorbita and see the fat whether it is healthy or if it is necrotized, or even with some severe cases we have even seen some mucor present engulfing the extracorneal and intracorneal muscles of the eye. So these are the post-operative pictures. So definitely surgical debridement is required, along with it medical management is indicated. Thank you.
Thank you, Dr. Kalyan. The rhino-orbital mucormycosis, once it spreads into the cerebral brain region, then it becomes a different disease altogether, and the prognosis is bad, and the morbidity increases. Now, to discuss this neurological aspects of this disease, I would request Dr. Suresh from the neurology department.
Good evening, sir. And today, now I will speak about the neurological manifestations of the rhinocerebral mucormycosis. As everybody was surprised why these many number of cases we are popping up when compared to the first wave, COVID wave. Like when I reviewed the literature throughout the India, the number of cases always in the world, we are the leading country for the mucor. Maybe because of the more population, or we know that most of the people, like diabetes is so common in our country. And what is specific about the why now only we are seeing the so many cases when compared to the other previous years. Maybe 2-3 things was which struck was we are seeing the different kind of people who are presenting to us. One, it is not that only sick people with the COVID-19 are presenting. The people who are at the home quarantine, not on steroids, are coming with mucor. There are very minimal symptoms who are on the 4-5 liters of oxygen are coming with the mucor. So if you broadly see, the people who are very sick are presenting, they are very small subset, and the majority of the subset, maybe around 70 to 80%, are not the very sick people with the COVID who are coming with the mucormycosis. So this shows that the COVID-19 per se is the risk factor to get the mucormycosis. Maybe it causing so much immunosuppression that it is inviting the opportunistic infections. And mucor is one of the opportunistic infections. And you have so many opportunistic infections. What is so special about the mucor? Why only we have to get the mucor? Maybe, like if you look at the literature, one of the thing is hyperglycemic state per se induces the glucose GRP17 receptors, which are like a portal of entry for the mucor. So that is called the glucose regulated protein. Whenever you have a hyperglycemia, that induces the endothelial cells will express these receptors. They allow the mucor to enter into the blood vessel. So this may be the one reason why, along with the COVID. And the second special thing about the COVID is it induces the hyperglycemia in a people with the COVID. Even the people who are not diabetic before, like we are giving the steroids for the numerous conditions, but we never experienced that the 4 mg or 8 mg dexa will lead to so much hyperglycemia. So this causes some dysfunction of the pancreas or the insulin related things, and there are 2-3 things you can say. So it causes the islet dysfunction, and at the same time we have a cytokine storm which itself implies the glucose tolerance. So these things may be causing the hyperglycemia. This hyperglycemia is made to express the GRP17-18 receptor. They may be allowing that one. So overall emphasis is proper control of the glucose. Like that is the only thing which is in our control to prevent the mucor. If the COVID per se is causing the immunosuppression and getting the infection, that we may not able to, that is not in our hand. So for the prevention point of view, it is the only control of the glucose. Remaining everything is hypothesis, taking a 4-5 times of the steam, using the industrial oxygen, or using the 3 or 4 times you are taking the swab from the nose. All these are the hypotheses. Really, we don't know really they are contributing to acquire the infection or not. So two common things now we can say these. One is a COVID infection per se, irrespective of the severity of the disease. And the second one is a controlling the hyperglycemia during the when we are treating the COVID. And what is why we need to be a very important when it comes to the CNS is the two important things. Once it invades the brain, normally itself drugs will not penetrate the blood brain barrier, so they are not very effective. Whatever the antifungal drugs we have, they are not very effective in treating the CNS disease. And the second thing is, whenever there is a tissue necrosis, drug itself will not reach to that place. So because of these two barriers, whenever it invades the brain, the prognosis is not going to be the good. And almost we can a mortality when it involves the cerebrum is almost around 80% in most of the cases, in spite of all the best available treatment. So the once there are two kinds of entry. Okay, this slide I prepared you can see these are the 3 institutes. One is from the NIMHANS and other one is from the Chandigarh and All India. You can see their number of cases almost for only 30, 50 and 70s. So very less number of cases. You can see the common risk factor to acquire the mucor is the diabetes, and that is you can see in a bold number. So the hyperglycemia is the most important risk factor. And the if there are 2 types of entry, you can see from here, once from the it can contiguous spread from the sinus, it can go to orbit. From the orbital apex, it can directly enter into the cavernous sinus. You know that cavernous sinus is a very tightly packed area where you have a carotid and you have all the ophthalmic 3, 4, 6 cranial nerves. So for example, if the sphenoid sinus also is just besides the cavernous sinus. If the disease spreads from the sphenoid sinus to cavernous sinus, they come with the pure neurological presentation. So pure neurological presentation means they can come just with isolated ptosis, they can come with diplopia, they can have just only sensory symptoms ipsilateral to the involvement of the cavernous sinus. So this is one presentation. Second presentation is because of the mass effect of the fungus on the carotid artery, you can get the watershed infarcts and patient can come with the hemiplegia. So this is without angio invasion. As long as disease is confined to the cavernous sinus and it has not invaded the blood vessel, at least we can expect the little better prognosis. Once it invades the carotid and enters into the vessel, then the prognosis is, it changes the prognosis, and what is the strategy you are going to use for the patient also will change. So the portal of entry from the orbital apex to cavernous sinus can present with the 3. One is a cavernous sinus thrombosis, where patient can have a proptosis, external ophthalmoplegia and pain, or isolated cranial nerve involvement, or compression over the internal carotid artery and causing the watershed infarcts, or angio invasion into the carotid artery and leading to the focal deficit based on the location where it is going to migrate. And the second one is a direct spread to the brain. Either it can be from the ethmoid sinus or the frontal sinus. They present with the localized abscesses. So when we have a localized abscess in a frontal lobe or the area where it has penetrated, so here is where the neurosurgical management will help. If it is a limited disease, debridement of the area where how the now the ENT and ophthal can help us in removing the area of the fungus involvement. The same way, if it is a non-eloquent area, so that we can debride that part and we can use our antifungal drugs effectively. So these are the common presentations, the same thing. So there is laboratory studies, there is nothing specific, and the CSF will not add much in this kind of things, and the cultures are rarely positive from the CSF. And the MRI will give the very important clue in the category, like a location of the disease, spread of the disease, and for the prognostic point of view. You can see this is from the contiguous spread. In the first two images you can see it as a abscess, and even in the third image. And this is just spread to the eye, and where the same sinus is showing the fungal involvement. And maybe because of this they are all calling the black fungus. So once the diagnosis, is made, the treatment, from treatment point of view, already discussed about the antifungal therapy. One is same the amphotericin B and isavuconazole, and based on the availability of the drug. So from the when we can say that okay, we will go this patient for the palliative care, that is the one important thing at this moment. So whenever there is a angio invasion, I prefer that at this moment, even with the aggressive treatment, it is difficult to give the promising outcome in those patients. As long as it is a localized disease, maybe it is worth going for the surgery. The similar factors. Yeah, thank you.
Before we start the question and answers, I would like to end this webinar with how to prevent this mucormycosis. So the first I would suggest to prevent is the vaccinations, because unless everyone gets vaccinated, no one is safe. So we increase the vaccinations and reduce the number of COVID infections can be the first step in reducing the incidence of mucormycosis. Then the second would be to very judiciously use the steroids. So mild disease should avoid using steroids, or where needed it should be used only under supervised use. Giving steroids in home kit and all I think is dangerous and one of the reasons why we are seeing such a high incidence of mucormycosis. And as Dr. Suresh has pointed out, strict glycemic control during an infection and even in the post-COVID status could go a long way in reducing this incidence of infections. And very judicious use of all medications, including antibiotics, antivirals, and monoclonal antibodies would help in preventing this problem. And of course, the last is the proper hygiene during treatment and good personal hygiene even in the post-COVID period. There are some studies which show it comes with a moist environment, like a reuse of the masks or badly dirty linen like things can. So improving a good personal hygiene can go in a long way in preventing this mucormycosis. Now I would request my colleagues Dr. Ajay and Dr. Mahesh to conduct a short question and answer session.
Yeah, we've had some interesting questions coming from the viewers. We've had almost about 150 viewers watching this, and we've had some very, very pertinent questions to the panelists. One of the questions was, maybe Pratik and Subramaniam can answer this. The clinical level, at their own clinic level, if they are suspecting some kind of symptoms suggestive of mucor, would they be able to initiate any kind of treatment at that time? And how soon should they kind of refer to a tertiary center? Clinic level management is what they're asking.
I think the patient has to be referred to the surgeon if it is cheek related symptoms or nasal, paranasal symptoms. it has to be referred to the ENT surgeon at the earliest. And depending on the imaging, at least imaging has to be done to confirm there is a presence of sinusitis. And in the appropriate background where there is a patient who has risk factors, if they have symptoms, and then you have a radiological features. So in those cases you can consider empirical therapy before you get a tissue diagnosis. Obviously in fungal infections I did not venture into that. You have something, there is a definition of how to categorize the fungal infections. You have possible fungal infection, there is a probable fungal infection, and there is a proven fungal infection. So one is when you have a basic suspicion, then in addition to the clinical features, then you have radiological proof or the biochemical proof, and the last, when you say proven fungal infection, where you have the clinical background with appropriate symptoms, radiological proof suggestive of that particular fungal infection or sinusitis, whatever it is, and then you have a histopathology or the microbiological proof that there is a fungal infection. So at least if you have a radiology backing you with the symptoms and all, then you can consider empirical therapy. So at least early imaging has to be done and early referral.
Adding to what Dr. Pratik said, what I suggest is, if possible, if at the dispensary or the hospital in a small setup level, if possible, better to do a nasal endoscopy, or as Dr. Pratik pointed out, get a CT scan. Other thing is the nasal sections, you can send it for KOH mount, so that if you diagnose, you can diagnose it. That is possible, and because better not to start empirically the antifungal treatment, because as you know it's a long duration and the cost also is very high. So better to have a radiological investigation like CTPNS, and the nasal smear you can send it for KOH mount and then come to a conclusion and then go for treatment. That I feel better.
The next question, again, I think Pratik can take this. I think you already mentioned it in your talk, but there was this question of if the patient is HbA1c positive and any kind of cirrhosis of liver, is antifungal treatment okay with them? Because most of the drugs are hepatotoxic.
The amphotericin group of drugs, the polines, are not hepatotoxic. You can have some hepatotoxicity with the azoles, the posaconazole and isavuconazole, but they are not contraindicated. Neither you do a dose adjustment. You just need to watch your liver functions carefully. So if there is no clinical suspicion or clinical signs of worsening hepatitis, you may repeat a LFT once in a week just to see what is the liver function like, and then you just monitor it closely. That's it. There is no need to avoid any drug because there is underlying cirrhosis. Definitely nothing in present, just HbA1c without cirrhosis, nothing differently to be done.
Again this question, Dr. Pratik, any antifungal drug you advise as a prophylactic therapy in high risk groups?
Okay, so I think there is no role of prophylaxis here for antifungal. Already I think we don't have enough medications to treat the patients. Definitely prophylaxis is not needed. Important thing is we have to cut down the risk factors. We have to cut down the use of steroids. You have to use it very judiciously. And next is glycemic control. Even if you do that, you can reduce the number of infections to a great extent. Definitely no role of prophylaxis in the current scenario. There is very limited role of prophylaxis in neutropenic patients of leukemia, but not in the current scenario, not for general population.
Question to the ophthalmologist, Dr. Pranati. Some of these patients with post-COVID suspected mucor, they are presenting only with epiphora, only watering from the eye, with no clinical evidence or radiological evidence of any invasion into the eyes, into the orbit. So what would you stage that as, and what should be the kind of debridement? Do you want us to break the barriers? Lamina looks pretty healthy. Lamina pepracia, there's no obvious invasion radiologically. only the patient is coming with epiphora. So what do you suggest in these kind of cases?
It's a Mucor-proof case.
Yeah, Mucormycosis case.
If there is no involvement of the orbit radiologically, we are not suggesting for any orbital medial wall resection as per se at that time, but these patients require a close monitoring and close follow-up. I mean, those patients, that's what I told in my lecture, those patients who presented to us in stage 1 and 2, in no matter of time, because of after we discharge them, because of improper glycemic control, and in some patients because of not using antifungal drugs properly, they again landed up with us after 1 week or so with the stage 3C and 3D disease. So if there is no eye symptoms per se, only just watering, I don't suggest any medial wall resection if radiologically if there is no involvement.
There are only two more questions. One is to Dr. Kalyan, the other is to Dr. Suresh. Kalyan, early debridement. When do we actually think of debridement in these kind of cases? One of the doctors have asked, patient is complaining of nasal stuffiness, a little bit of nasal discharge, and you are seeing just maybe a mucopus in the meatus. The CT scan is showing haziness. Would you go for a debridement straight, or would you like to further investigate?
Depends basically on the endoscopic evaluation. You have to do it. I mean, and the clinical symptoms should correlate. So only a normal sinus symptoms you can't just go thinking of mucor. We can't go, and we have to see the obviously the glycemic controls also. Then only we can decide.
This question, madam, direct question. Indications for orbital exenteration in rhino-orbital mucormycosis.
As I've told in the staging of the disease, in all those patients who have the extensive involvement of the orbit, that is stage 3C and stage 3D, as well as when there is involvement of the central nervous system, orbital exenteration is advisable to decrease the nidus of the necrosed and fungal elements in the orbit.
Yeah, last question I think we'll wind up with it's to Dr. Suresh. Number one is, what are the early symptoms which suggest that there could be an intracranial extension, because every one of us here in the periphery don't have an MRI facility. Number two is, during the COVID infection, when do we actually use steroids?
No, maybe any sinusitis with a confusional state. When you have a orbital pain or the like infraorbital pain or headache with a confusional state is the indication that we can think that there is some involvement of the either meninges or the brain involvement. Obviously, when there is a lateralized deficit, we will recognize it. Or intolerable headache, but we are seeing the very severe headache even with the sinusitis. So only confusional state I can say that without lateralizing deficit, if there is a confusional state along with the pain, you can consider for the mucor. And second thing what we noticed is that people who are in a ward who is suddenly developing the seizures, and when we did the imaging, it turned out to be a fungal. Maybe in a patient with the COVID who was in hospital developed the any neurological thing like a increase in terms of the headache or the seizures or any focal deficit, you can consider that there is some intracranial spread. If there is nothing, only sinusitis, if you have a confusional state, consider the involvement of the brain. Steroids, nobody knows exact answer for it.
I think with this we come to the end of this webinar. I hope it was informative. We got a lot of compliments on the chat that all the panelists were very, very informative and they explained their field sufficiently well. And I think with this we can close. We thank the KIMS organization and all of you, all the participants to be hosting this webinar and the participants actually participating in this forum. Thank